Hi, it's Dr. Centeno, and thanks for joining us this morning, this nice Sunday morning. Going to talk today about PICL testimonials, and that's mostly because patients have asked for them time and time again. You know, as I think you'll see as I go through the presentation, I've mixed emotions about testimonials, even though they seem to be a staple of the alternative health community. On the one hand, I think it's good for patients to see how their patients are doing. On the other hand, sometimes as providers cultivate testimonials, they tend to give sort of a false impression of procedure outcomes. But lots of people have asked, so here's what I went through to get some PICL testimonials for patients. So again, if you're just joining us, welcome in. Starting out with PICL testimonials, as usual, I'll give a 10, 15-minute lecture on PICL testimonials, and then you can ask questions. Feel free to ask any question you want about this procedure, about another procedure, about CCI, about something else, about what we're talking about not what we're talking about. Anything is fair game. So let's get on to PICL testimonials here. I'm going to go and share my screen. And go ahead and start this presentation. So again, this Sunday morning, we're going to talk about PICL testimonials. And like I said, I kind of have mixed emotions about providers only focusing on testimonials. And a lot of that has to do with the fact that I think providers obviously cherry pick the patients that are doing the absolute best and tend to ignore the patients that are doing the absolute worst. And so testimonials kind of put out a false narrative of how well a procedure works or doesn't work. And so consequently, I've kind of avoided them. Now, having said that, I just keep getting beat over the head by patients asking for testimonials. So I said, okay, I'm going to do testimonials, but I'm going to do them a little differently. I'm going to do them my way. So first, like, comment, share, subscribe, because that's how we get content like this out to more patients. So if you're a patient that cares about, you know, how all this goes down, hold on a second here, I got to fix something on this. And, you know, you feel a sense of obligation to other patients like you, then, you know, liking, commenting, sharing, subscribing can get this type of information out to other patients. So, you know, we've completed and published 2 PICL outcome analyses online, freely shared that data, the good, the bad, the ugly. Now, the third is in progress. It's taking longer because it's going to be published in a peer-reviewed journal, along with a new CCI grading system, the one that I usually talk about here. And while that may seem second nature to you and I now, it's not second nature to doctors out there. So we've got to get that out there as well. And despite spending dozens of hours analyzing data and now spending several hundred getting a third analysis published in a peer-reviewed journal, I still get asked for testimonials. And like I said, one concern I have about testimonials is that they tend to be cherry-picked. The patients that are doing the very best are the ones that get cherry-picked. And then that, I think, many times gives a false impression of how well a procedure works, because what never gets focused on is when the procedure doesn't work. Now, I see patients in clinic 3 days a week who are doing quite well. I do probably 80% of the procedures I do right now are PICL. And so they're making gains, but I'm, again, not the kind of doctor to turn every PICL fan into a video testimonial and shoot that out there. Now, maybe that's to my detriment, but Hopefully it's not, meaning hopefully it's to my benefit, meaning I'm trying to paint an accurate picture of what this procedure can do or can't do. So here's how I went about this. Rather than cherry picking testimonials, in fact, as I was getting ready for this morning, I said, oh God, I should have included the 3 doctors, or actually 2 doctors and 1 PA that I treated, that all got 100% better from a single procedure because we had gotten them within that first 6 months of their illness and their injury. But again, that would have given a false impression about most patients that I see. So what I did here is I asked for PICL testimonials. You probably saw me do that here in this venue. I went through some other venues. Obviously, people are busy, so we got 6 people that sent in some testimonials. I tried to make them regimented, meaning so that patients would answer certain questions. One guy didn't follow that. He gave me a video, so I tried to transcribe the video. One patient was right in the middle of a big surgery, and while she had done well, I didn't feel it was fair to share her outcomes when she's right in the middle of a big surgery or has just done that big surgery and is recovering from that surgery. So we're going to hear from 5 of those testimonials today. And I didn't use anyone's name. I didn't feel right doing that, even though some patients said use their name. Other patients were much more shy about it. So it's just patient B, patient A, patient V, patient T, whatever. That's just my own internal name, so I can find these people if I need to. So this is patient B, just had another PICL. I think that was the 3rd PICL. So this is the outcome after 2 PICLs, estimating improvement at 60 to 70%. Some big things couldn't do before. Important thing is I'm able to work again. And additionally, I was able to climb approximately 2,000 meter mountain. Pretty good. As you can see, he's got his symptoms listed there. He's very, very meticulous here. Dizziness has gone down from a 6 to a 2 out of 10. Visual disturbances from a 5 to a 1. Concentration difficulties from a 5 to a 1. Headaches 3 to 4. You can read the rest there. And then it's important that he puts down here that despite these improvements, I still have some limitations. And so he lists the limitations. And again, if I'm going to do testimonials, I'm going to take the good with the bad, meaning that you can certainly see testimonials online that are rah, 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 never focus on anything that isn't perfect. I'm not going to do that. So I allowed him to put a paragraph down here for him to explain why he got his 3rd PICL. That just happened literally a week or 2 ago. And because he's still got some things that need to get better. So that's the way I'm going to do testimonials. Patient A. Now, this is a guy who pretty strictly followed what I put out there. Answer number 1, what improvements am I noticing? Have remarkable improvements in sleep and waking up with no pain at the end of the day. Near full mobility of the neck, able to digest food, have regular bowel movements. My health is near what it was pre-accident 15 years ago. So this is a patient who has been struggling with this for quite some time. Improvements in mood, anxiety, etc. 95% relief, 2.5 months post PICL 4. So this patient has done 4. Remember, I usually quote, most patients are going to need between 2 and 4 PICLs. And what activities can you do now that you couldn't do before PICL? Played hockey, played goalie. And then you can read the rest of it there. He was able to wear a helmet. Miracle worker, this guy's in Canada. Patient J. What improvements have you noticed? I've had very tangible improvements from my procedures to include a drastic decrease in daily average pain, gives his pain there, rarely spikes above a 5. I've also had substantial increase in neck stability, could not sit or stand with my neck unsupported for periods longer than 1 to 2 hours. Now I have no restrictions with my neck being unsupported. How much relief you've experienced? 70 to 90%. What activities can you do now that you couldn't do before the PICL treatment? Can work 40 hours a week at their job, attend concerts and sporting events, drive for periods longer than 3 hours. So pretty substantial, solid improvements in patient J here. Patient V. Now, patient V gave a little extra information, but I put it in here because it's good, I think, for patients to see. This patient was in a severe auto accident in August of 2012, so had these issues for quite some time, and talks a little bit about the accident, age, accident, all the rest of it. So I think that's important for patients to see. PICL number 1, not fully successful because we had some struggles with the airway and problems with blood pressure, but still pretty good results, 50, 60% better. So all that means is that in PICL number 1, we had to cut things back a little bit because of issues we were having with anesthesia. Now, this is a good example. Patient came back, corrected some things, and PICL number 2, we were able to get it all done and doing really well. And so improvements that they've noticed, able to be active for 12 hours versus before PICL number 1, only 6 hours, not fatigue, tremors gone, anxiety gone, blurry vision gone, overall pain level and need for Tylenol significantly improved. What are the percentages of improvement after PICL 1? 50 to 60%. After PICL number 2, 70, 75%. And what activities can you do now that you couldn't do before? Walk 3 miles, carry grandson who's 30 pounds now, and drive for 2 to 4 hours. And then patient L, this guy, liked doing videos, so he sent me a video, and so this is after 2 PICLs and getting to number 3 soon. Now, I did like that he sent me a video because I remember my initial interview with this guy, and just how muted everything was in his personality. I mean, he looked sick. He looked like he felt sick. And that's not the case anymore. He's animated. It was great that he sent me a video because I could see those differences just in his face. So these are some of the things he said. I took these from the video, the 2-minute video he sent. Used to be nauseous, now gone. Room spinning, pretty much gone, but his eyes are still weird. Neck not as stiff. He doesn't need to turn his whole body when he looks at something. He can walk around now and be touched, which is a big thing that his family has noticed, because before, anytime anyone touched him in like a social setting, it would just blow his world up. Still gets intermittent chiro adjustments and wears a hard brace when he drives. And interestingly enough, this is not something I hear a lot from patients, but he gets periodic CSF drainage when his intracranial hypertension is quite bad. His DMX showed improvement after PICL number 2. So he's going to be getting PICL number 3 pretty soon here. So in summary, in the future, we'll do a better job of collecting testimonials as patients like to see them. I don't think I'm ever going to be that kind of doctor that shouts from the mountaintops and takes a video of every single patient that's doing well, but ignores the patients that are doing poorly. And realize that most of our patients have failed things like curve correction, upper cervical chiropractic, numerous prolotherapy visits in Florida, styloidectomy. Some have had tethered cord releases. Some have had tendon dry needling that wasn't successful, etc. Also realize that the data analysis number 3 that we're working on should feature PICL versus ePICL. So I'm letting a little bit more time out there get under the ePICL procedure. That's one of the delays. CCI type versus outcome. I think that would be very important. My sense is that certain types of CCI probably do better than others. And the key elements that make someone a poor candidate, we're going to be looking out for those in the larger data set. Assuming that the smaller ePICL data set will probably follow. And publication, obviously, in a peer-reviewed journal. So sitting here before we complete the 3rd PICL data analysis today, what are the factors that I think reduce outcome? Sort of a question I gave myself, right? As if someone had had asked it. Well, the first is, I talk about this all the time, right? If you're more than 12 to 18 months out from your initial injury, that takes a hit, right? Outcomes go from about 80% successful and from a single procedure or a one and done to 70% successful, needing multiple procedures. Now, most of our patients are not in that 12 to 18 months. As you saw, one of those patients I talked about that did great was like 10 years out. So they still do well, but they need more care. And, you know, the success rate goes from 80 approximately to 70%. I would say it's even higher than 80%, but I'm being muted there, meaning if I look at my regulation or what I remember with regard to the number of people who we've had in that first 12 to 18 months since injury, it's probably higher than 80% that have gotten better with a single procedure. Another thing I get concerned about a lot is concomitant alternative medicine diagnoses that are being aggressively treated. And what I mean by that is severe POTS when someone's got a central line in, severe POTS when someone has polypharmacy. What I mean by that is they're on, like one patient I reviewed recently here this weekend, a dozen or more different medications, half of which are probably interacting with the other. Someone who's being actively treated for Lyme disease. As I probably told you, I don't think Lyme disease has anything to do with the status of your ligaments, nor do I think it has anything to do with craniocervical instability. Same thing with CIRS, mold, etc. It's not that these patients can't get well. It's just that I find a lot of this stuff a distraction in trying to get them well. And so my sixth sense is it probably makes a difference in outcome, but it's one of the things I'm going to test in the third data analysis. Prior surgeries like a prior styloidectomy, detethering, decompression, fusion. Now, I've seen some people do well with a PICL and then getting detethered. I think I've seen more patients after detethering who did poorly from detethering and who now we're trying to rescue and it's hard to do. Or more patients who do poorly with a styloidectomy and we're trying to rescue them after the fact, or same thing with a Chiari decompression, or a patient that has a neck fusion and then wants us to treat them. Polypharmacy is a big one, meaning if someone's on a dozen different medications, that's concerning. Patients on prior narcotics, that need to take narcotics to function. Low dose naltrexone, I think I've talked about. THC, I've talked about, and how those two can impact anesthesia and our ability to get things done during a procedure. Patients that use a collar all the time to function are always a concern because that's a very deep hole to dig when it comes to trying to get the neck muscles back online. And then we see a few patients that are older and have these significant blocking bone spurs in the upper cervical spine that prevent access to these PICL injection sites. Okay, so let me go ahead and stop my screen share, and I will go to answering and trying to get to as many questions as I can. Peter, hey Peter, good to see you here. What's the weather like in Denver? Traveling there next week. It's been pretty good. I'm in the mountains right now, so it's a little colder up here, but I don't actually know the weather in Denver, but I'm going to find out. Weather in Denver. So high today in the 70s. Yeah, it looks like it's going to be like that. Now, I guess midweek next week, we do have a little tiny bit of snow coming through. Probably, I think that's the first Denver snow. But then it gets warm right afterwards. So usually that happens in Denver quite a bit. I think a lot of people are used to snow sticking on the ground. In Denver, if snow's on the ground for more than a couple of days, we all start getting very, very cranky because we're not used to it, meaning it usually snows for a day and then it's 60 degrees and it melts. So that's what it looks like. Jessica, in your opinion, what's the way to get a diagnosis and treatment of a CSF leak? What imaging can see this? Jessica, it's very difficult to get imaging that's accurate for a CSF leak in my experience. Radionucleotide cysternography is one we've tried. It's supposed to be accurate, but in slow leaks, which is what most of these occult leaks are, in my experience, it doesn't usually show it. You can try to take specialized skull-based MRIs, for example, to try to see if you can see small fluid collections, but I think that's got a very, very high false positive rate, meaning what that means is that you think you see a fluid collection, but it's not due to a leak. So CSF leaks are very difficult to diagnose. That's one of the reasons why I take a very pragmatic approach to them, and that is if you have a CSF leak, the biggest thing that I see is that you're going to feel awful and have an ice cream-like headache when you're up, and you will feel dramatically better as soon as or very shortly after lying down. That's pathognomonic for a CSF leak. Now, if you're lying down and you notice that when you turn your head too rapidly, things get all pissed off, that's not a CSF leak. Or if you're up and about and you're fine until you turn your head, that's not a CSF leak. So it's important to know the difference there, because I think what I've seen as a doctor is I've seen a lot of patients get a lot of surgeries for CSF leaks. And because they keep expanding out the definition of identifying a leak, I think that we're seeing a lot of patients who are operated on who really don't have leaks, or at least they don't have leaks that are causing symptoms. And so the outcomes of the surgeries, from what I see, aren't that great. Natasha, tips for getting dental work, cleaning when you have CCI. Yeah, Natasha, I think the best you can do is to talk to your dentist about what that is. I almost might recommend going in with a cervical collar on so that the whole team recognizes that you have a neck issue and is careful around your neck. That way, I think it gives the whole dental team some acknowledgement, hey, this person's got a neck problem, I got to be careful here. Allison, hi, Dr. Centeno, what are the outcomes been like for Sears patients? Also, how many months after PICL it's okay to do mold remediation? Yeah, Allison, I don't think Sears has any play at all here in CCI. So I'm agnostic to it. As I said before, one concern is that patients with multiple alternative health diagnoses, meaning Sears is not a medical diagnosis. The traditional medical care system doesn't recognize it at all. It's an alternative health diagnosis. So my concern is that it tends to be a distraction when we're trying to get someone better from craniocervical instability. So to summarize, number one, no overlap at all that I see between Sears and CCI. Number two is it tends to be a distraction. Number three is I'm pretty agnostic to the whole thing. And I don't think there's any relationship between mold and craniocervical instability. Jessica, do you recommend any supplements to strengthen ligaments or speed up healing? No, I don't think any supplements will do it unless you're malnourished. So if you're malnourished, that's one thing. Then supplements might be very, very helpful. But I think if you're eating a normal, healthy diet, I don't think supplements are going to make a difference in your ligament healing. Now, one of the things that can happen is that patients come to us, like a lot of Americans have, with metabolic syndrome. And that means they've got higher levels of systemic inflammation. So many times we'll put them on our stem cell support formula because it's highly anti-inflammatory. It's got lots of anti-inflammatory components in it to try to manage that systemic inflammation. Zach, how does a full body MRI compare with site-specific MRIs for tendinopathies, arthritis, and disc degeneration? Maybe cheaper for all the areas I need to check on. Full body MRI is nothing more than sort of a very loose scan. And what I mean by very loose scan, what that means is you're not getting a lot of details. So it's really focused on trying to see if there's tumors that are being missed. That's usually what full body MRIs are done for. So I wouldn't recommend, for instance, a full body MRI to see if you have an issue in your knee, or a full body MRI to see if you have an issue in your neck, you need site-specific MRIs for that because they have much, much, much more detail. Christy, I know heat is okay after PICL procedure, not ice. I would think this is due to the inflammatory response. After procedure, can you take a hot bath? Yeah, I mean, you could take a hot bath just literally within 20, well, let's say 48 to 72 hours. The only concern would be the bone marrow aspiration sites and trying to make sure those are epithelializing and healing over before you immerse yourself in water. That's the only restriction there. Natasha, if you did have to have neurosurgery, is there someone to find? List qualified, lots of experience with surgeon, CCI. Yeah, you only have 5 choices as far as I can tell. There's 5 surgeons that probably do 80% of the craniocervical instability surgeries. Dr. Henderson in Maryland, Dr. Patel in South Carolina, Dr. Bolognese in New Jersey, Dr. Frank in Florida, and Dr. Gillette in Barcelona. Those are the 5 neurosurgeons that do the most of these surgeries. And if I were a CCI patient that needed surgery, I'd see one of those 5 guys because, you know, it's hard for patients to understand that doctors are like everyone else. Repetition in any procedure breeds competence. You start to understand what not to do and what leads to complications. You start to understand how to get from point A to point B in a less traumatic way. You start to understand how certain patients probably shouldn't be getting your procedure while other patients should. And, you know, those are the only 5 surgeons I know that do enough of this type of CCI surgery on a day in, day out basis that I would trust with having learned all those little parts and pieces of CCI surgery. Jessica, in your opinion, how poor are the outlooks of fusion surgery? Like a person should only pursue this after they are like bedbound all day. Not really that, but I think like anything else, right? Fusion is a big surgery, and I always tell my patients it's a dog with fleas, meaning that it has known side effects in adjacent segment disease being one, meaning you fuse one area, you're going to overload another. In this area, it's also a very big surgery that has a pretty high complication rate in of itself. So if it were me, I wouldn't consider fusion surgery until I'd tried all the conservative options. That would include PICL if I was a candidate. I wouldn't think about fusion surgery unless I was disabled because it's a risk-benefit calculus, right? If you're disabled, you're willing to accept more risk than if you're highly functional, for example. Submitted advanced by Sherry Scott. Is there any chance the PICL procedure will ever be done in Texas? Not at the moment. Just so you know where things are there. We are going to get that publication out the door. And there's already multiple providers in our office doing PICL because they've had enough one-on-one training where they're very competent in it. As far as training others outside the office, that's going to be a big deal. And I think something that most doctors won't accept, meaning that most doctors want to go to a weekend course, learn how to do something, go home and experiment on patients. That's not going to be the format when this gets taught. Those doctors will have to spend a significant amount of time at our clinic away from their existing practices. They'll have to withstand substantial income loss during that time for me to feel comfortable that they're competent. And so when will we get to do something like that? Probably in 2026, would be my guess. But that's a guess. And where those providers will be will depend on where providers who have the base criteria, which is not many, less than 100 U.S. physicians would meet the base criteria to do the procedure, meaning that they've done a lot of upper cervical work and have treated a lot of upper cervical patients prior. Who's willing to give that amount of time out of their practice and lost income in order to learn this procedure at a high level. Peter, when do alar ligament injections? What are the best? When do, or when you do alar ligament injections, what are the best recommendations? Avoiding physiotherapy or the opposite? What is recommended time to return to rehabilitation is not damage the alar? Yeah, so that's on a case-by-case basis, Peter. What we like to see there is that the patients meet certain milestones, right? So, for example, there are patients who might be in the one and done category where for 3 or 4 months after their procedure, they've had enough improvement where we may then recommend they start rehab at that point. Usually what we'll do, though, is to make sure they can do the online exercises first before we prescribe more formal in-office rehab. But then there are other patients who may have only gotten 20% relief. They still have lots of problems where we won't even have them do the online exercises because they're not ready yet. Reese, do you see a big jump in improvements after the patient has 2 PICLs versus just 1? I know it depends on the patient. Yeah, Rishi, that's, very, very patient dependent. I will say this, that after starting to allow a patient who didn't have good results after the first one, meaning they just didn't seem to do much, to do a second one, we do see a patient population that does really well with the second one. So that's about all I can say about that. Submit advanced by Harry Winston. How long is the average recovery time for the PICL procedure? Yeah, usually it's 3 to 7 days. What that means is that there's 3 to 7 days of increased symptoms. About half the patients have a honeymoon in there. So for a week or two, while they might be sore or have some increased symptoms, they actually feel better because there's swelling in the ligaments that provides stability. And then we do have a subset of patients that have longer flares lasting weeks. And then even a smaller subset of patients after that have longer flares lasting months. That last patient group is becoming less and less common because I no longer allow patients that are that sensitive to undergo the full procedure. I think that's helped reduce those longer term flare-ups quite a bit. Peter, do you more often deal with patients who have damaged the ligaments one side or both sides? I would say it's more common to see both sides than one side based on what I recall. Tasha, just had my PRP procedure on cervical, sacrum, and ribs 4 days ago. Is the flare-up inflammation stage the same time frame for a PICL procedure, maybe less? Usually less. Usually posterior procedures like that have a much lower amount of flare-up. Smith advanced by Jocelyn Smith. Is PICL procedure more suited to people who have traumatic injury from something like a car accident? It can also help people who have severe upper neck instability from things like EDS. Both. I would say probably at any given time, a third to half of our patients have EDS. And while they need more treatment overall, they do just as well in the long run. So both. Natasha, appreciate today's presentation. Sure, Natasha. Again, patients ask for testimonials. So I wanted to try to give them something, but something a little bit more in my style rather than rah, 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 rah. Peter, how would you compare BMC to highly concentrated PRP in terms of raw material for ligament repair? Is the difference in chemical composition, amount of growth factor is significant? Yeah, there's a pretty significant difference between those two. So the example I like to give is women with SI joint instability. If we're going to use prolotherapy for women with SI joint instability, it's 6 to 8 visits. If we're going to use PRP, it's half of that. So rather than 6 to 8, we're looking at 3 to 4. And if we're going to use BMC, bone marrow concentrate, it's half again of that. So really more like 1 to 2. So that gives you some idea of the relative strength of all those three. Criminology. Natasha, I usually wear a soft collar. I got that. Peter, have you had any dealings with physical therapists to help CCI patients with an occlusal splint? Can this help with PICL? Yeah, yes and no. I've certainly seen a lot of patients treated who have concomitant TMJ and CCI with occlusal splints. And so I think an occlusal splint can take some of the pressure off of the upper cervical spine. I think the downside of splints is that many patients get dependent on them. And so we're just shifting from one problem, the upper neck, to the other, the TMJ. Lisa, have you used PICL and instability of C1 with associated scoliosis? Yeah, sure, quite a bit. So those are our type 1. If you're talking about 0-1, meaning doctors tend to focus on the level is defined by above and below that level, meaning the movement level, so 0-1, 1-2. But yes, we see patients with C1 issues all the time. We have lots of patients with scoliosis. I will say, just realize that associated scoliosis causes rotation at C1, C2, and there's not really much we can do about those additional forces up there. So we can stabilize it, but you can't fix the rotation all the way in a scoliotic patient. Gianni, filling out paperwork now to have a consult with you. Does a virtual consult for someone who has had these injuries for a long time suffice? Do you recommend coming in to consult you in person? So to answer the first one, virtual consults work great. Obviously, there's some things I can't do. So if you are local, or if you've got family in Denver, or find yourself in Denver, I'm happy to do it in person as well. Obviously, it's a little bit more in depth on it in person because I can do a hands-on physical exam. Number 2, I've done NUCA for 8 months with some help, but jaw and ribs have gotten worse. So I tried AO in North Jersey, but he hasn't been working out well. I tried to get that AL or AO maybe to talk to Dr. Rose about my case, but I didn't think that was necessary. Yeah, so I will say this. One option may be that it's just the instability is the reason why it won't hold. The other option is, I think you had a good instincts reaching out to Dr. Rosa, because he's a master, I find, in helping local AOs understand what it is they're dealing with and adjust their vectors. So I've seen him countless times give information out to local AOs that has been very, very helpful. All of a sudden, the patient starts responding to AO, whereas before they weren't. Daniel, how do you treat arthritis on the C1 lateral mass? Daniel, I need a little bit more information on what it is you're talking about there. Arthritis occurs in a joint. So specifically, which joint are you talking about? Are you talking about the 0-1 facet joint, the 1-2 facet joint? Both would involve the lateral mass, for example. But if it's 0-1 or 1-2 facet joints, that's X-ray guided, contrast confirmed, digital subtraction angiography, injections of either PRP or bone marrow concentrate into the arthritic joint. AT, hi doc, you likely had exposure to several PT approaches. What's unique about IPA-PT that makes it stand out so much? Yeah, the biggest thing is probably that IPA-PT doesn't believe in the weekend course model. Most of PT is based on the weekend course model. So that is, someone goes for a weekend course, they learn something, they go back into their clinic, they may or may not be any good at it, and then that's pretty much the extent of their education. IPA-PT requires them to go through certifications, they've got fellowship programs, they recognize that the more education someone has beyond just a weekend course, a single weekend course, the more likely it is they're going to be able to help people. They also have a very sophisticated hands-on manual approach. And they also see CCI patients, so it's a good fit. ATM exactly 2 months out, PICL, doing CBP, but too eager to try to get muscles online. Should I wait a bit more to heal? Yeah, I think you should wait a little bit more to heal. AT, I think I know a good idea. I know you're trying to thread that needle between staying as active as possible and pushing, but certainly a good time to lay off a bit would be in this initial healing phase. Peter, can you tell us more about the change of technique reaching the central part of the alar ligament, briefly speaking? Peter, I think I've talked about it a couple different times. It's a different way to access the central part of the alar ligament. very different than what was being done before. I'm hesitant to discuss how that works because I've already been burnt by someone from Europe showing up in my clinic, claiming they were there for reason X, but really being there to see if they could watch one or two PICL procedures and then try to turn that into a see one, do one, teach one, and go home and try to do this bastardized version of what it is I do. So can't really get in too much more detail other than to say it's a far superior way to get into the alar ligament. And it's also helped redefine the ligamentous anatomy that we see on fluoroscopy with contrast conformation. And what I mean by that is there was no text when we started that we could go to and say, well, when we're in the alar ligament, this is what it looks like, or that when we're in the accessory ligament, this is what it looks like, or that when we're in the transverse ligament, this is what it looks like. All of that had to be learned, and we're still learning. So it's, we're getting to the point of mastery of all these upper cervical ligaments, but that took a decade. 10 years to get there of doing these procedures. Now, most of the learning came in the last 5 when I was doing a lot more of these procedures, but it's that eye to continuous improvement that makes the difference. So it's hilarious. You can't come in and see this procedure once or twice and pretend you know what it is you're doing. If anything, you know enough at that point to be dangerous. AT, how important do you think implementing gyrostim is for getting to maximal recovery? I think that's patient specific. So for patients that don't know, gyrostim is this thing that's mostly used in athletes where it's to do hand-eye coordination and through the neck and the vestibular system. So you're holding a little laser pointer and you're pointing at various targets while they pertubate you in this chair. Now the chair can even go upside down or sideways. I think that we have had patients that have used gyrostim, that have used it to sort of get rock solid in their recovery, but not for all of our patients for sure. I would imagine that a good half of our patients would never be able to tolerate how aggressive a gyrostim can be. Jessica, from a CCI patient, sometimes doctors gently pull up on the head for various tests. Is there any way gentle pulling up the head can stretch a ligament? Not so much, as long as the doctor's doing it gently. I don't think it's going to cause any permanent injury. Now, it may piss off someone's CCI, though, so realize that those are 2 different things. Lisa, I have a question about completing one question in pre-screening document, but have left helping message and text, no one replying. Any suggestions? Sure, yeah, just send me an email directly, Lisa. I am putting my email in the chat here. If you're ever having a hard time reaching staff for whatever reason, don't hesitate to reach out to me personally. So I just put the email that goes to my desk. Just reach out to me and I'll see if I can resolve it. AT, any opinion on supplementing with creatinine to help atrophied muscles online with PT? Don't really have an opinion on it. Daniel, my injury is worse than extension. Do you see that people of this type of CCI type respond well to PICL? Yeah, actually, I don't think this is out yet, but I have a video that goes into symptoms with movement and what type of CCI that could be. What that talks about is that's usually a skull sliding type CCI or a 1C. We treat those patients all the time. They do quite well. Strange. Higher C, if progesterone can cause ligament laxity. No evidence that I know of that progesterone and progestin can cause ligament laxity. Now, there is, interestingly, some female ACL ligament injury data that seems to show that it could be related to female cycles, but no one's quite sure what's causing that. And in fact, if I recall, when women were on their menstrual cycle, they were less likely to injure their ACL. So again, no one's quite sure what to make of all of that. Daniel, do you think it's important to be in alignment after a PICL? Again, Daniel, as I always say, if someone has a good relationship with their AO or NUCA chiropractor prior, and it helps, I would continue to play right through there. What we generally don't like patients doing is kind of starting that stuff afterwards when they don't know if it's going to help or not, meaning some patients just aren't a good fit for AO or NUCA. So that's generally how we deal with that. Deanna, do you need a specialized dentist to understand the serious relationship between jaw and cervical spine to make the correct retainer? Are there any over the New York City area? Nobody I know of. Again, Dina, I think what we're seeing is that you can kind of offload the upper cervical spine sometimes by using a splint. But again, then patients get dependent on the splint. So in general, I try to avoid that kind of stuff, using that kind of stuff. Now we have patients that come in all the time with splints, and we help patients manage those. Natasha, we figured a way to work on cardio safely. I'll give that to the group. HFBHJ, can a mildly lax nuchal ligament cause the head to feel heavy? Could be. Usually when the head feels heavy, it's because of atrophy or atrophy of the upper cervical muscles, or those upper cervical muscles are offline. Less having to do with things like mild laxity in the nuchal ligament. Lisa, I have pain in my legs and feet when C1 is adjusted by the AO chiropractor, and this reduces or eliminates. Have experienced this sense with other patients. We have, Lisa. That's a pretty common one, that patients have pain, numbness, tingling in different body parts, and that feels better after they get put in position by a good quality AO or NUCA chiropractor. HFBHJ, why aren't naturopaths doing prolotherapy? Shouldn't it be, or why are they doing it? Should only be an MD or DO training with ultrasound C-arm. Also, for people watching, DO is the same as an MD. My uncle's a general surgeon, is DO. Yeah, I would agree with you. I think naturopaths doing procedures is dangerous. I've written about that in the past. I've sourced opinions about that from other colleagues. We even put out a white paper on it signed by a couple dozen interventional spine physicians, by myself, stating that naturopaths doing prolotherapy or deep spinal injections was dangerous. I still believe it's dangerous. I don't believe they've got the training to do this. I think the reason we see it is that in some states, it's quasi-legal. So for example, in Utah, there's a guy in Utah doing a tremendous number of spinal injections, irresponsibly, in my opinion. And in Utah, if you read the Practice Act for Naturopaths one way, it would seem to authorize it. But if you read it the way most people would read it, it clearly doesn't. So Arizona is another big problem state as well. We have lots of naturopaths doing all sorts of crazy things in Arizona because the Naturopathic Practice Act is kind of vague on what it is they can and can't do. Other states, less of a problem, but what I've seen is naturopaths in Arizona and Utah trying to push other naturopaths around the country to do more beyond their practice acts, because most practice acts clearly don't allow a naturopath to inject into the spine. So it's kind of a mess right now, having to do with differing practice acts in different states, but it's all dangerous in my medical opinion. Daniel, how many in the US do you think get CCI every year? 1,000 or 10,000 people? Yeah, it's a good question, Daniel. I'm going to guess it's more like 10,000, be my guess. Meaning that I would see a tiny percentage of the number of people who probably have CCI if everyone got diagnosed. Now, how many actually get diagnosed? I think that's probably closer to 1,000, meaning 10,000 probably have it. 1,000 get diagnosed, and I see some percentage of that 1,000. But I think there's a lot of undiagnosed craniocervical instability out there. For instance, I think there's a huge overlap in people who are told they have concussions after hitting their head. I think there's a significant chunk of those patients where the brain injury resolves and they still have symptoms from craniocervical instability, but it never gets diagnosed because they're in the wrong place to get that diagnosed. Dina, what do you mean when you don't allow overly sensitive patients to do the full procedure? Do you less invasive procedure, being at a slower pace? How does that work until you? Yeah, so Dina, what that means is a patient is centrally sensitized on exam and I had one of these in the last 2 weeks, where we won't allow them to do the whole procedure. So commonly what I'll do is I'll just focus on bone marrow concentrate in the ligaments only. So I won't do the facet joints. I won't do some of the nerves that need to be done. And in my experience, that dramatically reduces the flare-up. So it's the less is more concept in that crowd. And if you use less and more, eventually you'll be able to do more, because getting some stability will help reduce the sensitization. And then eventually you can do more as time goes on. So less is more is the approach in those patients. John, do you believe the ePICL can be up to 80% effective? I think so. Yeah, I mean, it's definitely a game changer. I think we'll look at that data. Like I said, I'm trying to give a little more time in the existing data collection, because we only started ePICL in April or so, and here we are, or I started in April, and here we are in end of October, early November. So even if I get 8 months on ePICL, I'm only going to get some people that have 1 treatment, some people that have 2 treatments, etc. So trying to give it a little bit longer to see if there's a difference I can detect at 1 to 2 treatments versus the larger group who's had more. John, do you believe yeah, I think I answered that one. John there. John, thanks for taking time to address PICL testimonials. Out of the 500 plus showed school reviews and thousands of PICLs, for only 7 people who felt impact enough to leave a review. Of the 7 reviews, 2 felt as they were made worse. Yeah, John, but I think that's because the squeaky wheel gets the grease, right? At the end of the day, people are, I think, more inclined to leave reviews when they're trying to get back. And we're not the kind of clinic that's out there like some, shaking people for reviews in the same way that I'm not shaking people for testimonials. So I can tell you that 2 out of 7 is not the number of people that get worse after a PICL. In fact, long-term flare-ups lasting 3 to 6 months in my existing patient population is about a 1 in 100. So that gives you some idea of how slanted all of that stuff can be. So unlike, buying a new phone or buying a new computer, this stuff on reviews gets much, much more complex. And many, many doctors cultivate their reviews pretty aggressively. Certainly many alternative health practitioners do. We do not. Danielle, what does it cost to rent and live in Denver per month? It's a good question, Daniel. I wish I knew. I'm guessing that you could get a VRBO monthly rental for $2,000 a month, but that's a guess. I really don't know. I haven't looked at that. AT, as a splint issue with dependency, I've seen some stories of some patients that begin, and then actually, let me go back here on that one, John. John, what I'd encourage you to do is to get on the PICL Facebook group. We're not on that group. We don't control that group. That group is controlled purely by a patient. Dan Semrad, who decided to take the time to put it together. Dan is a full-time engineer. So you got to really thank Dan for the time he takes to help run that group. But that's the best place to see what real patients are experiencing. And it's also good because I think Dan tries to weed out the folks that are trying to have an outsized voice and just complaining. So, I think it's a good cross-section to try to get information on. As far as the splint issue, dependency, I've seen stories of some patients that begin working with our dentist try to change the bite, not to be dependent on the splint. Yeah, again, it's a little different here though, right? You're getting a splint because it's trying to offload the upper neck. So then you got to fix the upper neck and then you can get rid of the splint. But all too often what I see is that the patients just stay with the splint because it seems to help their upper neck long term. Gianna, I know that alar and transverse ligament damage because DMX, but I had suspect more ligament issues in other areas like jaw, shoulder, and ribs. Yeah, so Gianna, we help lots of patients with ligament issues in multiple different areas. We try to treat the whole patient, not just one tiny part of the patient. So yes, we do that all the time. Gianna, do you recommend trying to work out or anything or wait until consult with you post procedures? Yeah, I think it's always best to follow up with your doctor who did the procedure to get the thumbs up on doing certain things after a procedure. Gianna, for HEDS patients not holding in line with the AO, can they still have PICL and need to be in alignment? Same rules apply as I discussed before, Gianna, for HEDS versus normal ligament patients. Daniel, so arthritis between C1 and C2, left side of C1 lumbar, some kind of bony growth occurring, growing down left. Anyway, treat stop of bony growth. Yeah, so Daniel, I think what you're describing is C1, C2 facet arthritis. So again, that gets treated all the time with PRP or bone marrow concentrate into the joint, but that's an X-ray guided, contrast confirmed injection with digital subtraction angiography. That's not something that's done in a prolo office, for example. And as far as the bony growth, I think what you're describing is off the transverse process of C1. There's an intertransverse ligament that goes south and an AO ligament that goes north. So it sounds like too much pulling is occurring on the end of that transverse process, and that's causing a little bone spur to develop going downward there. Common problem, it's usually happening because of the instability. So the goal is to get rid of the instability. Vivan, what's the role of T2 in triceps, chest, posterior sensory only sympathetic symptoms? I have paresthesia, rest of my chest goes down to legs, MRI clear. Yeah, so I mean, you could be having problems in the thoracic outlet there because the nerves will come in, go through the thoracic outlet, dive down the T4, and then go up. You could have a T4 syndrome or T3-4 syndrome where there's some segmental motion anomaly happening in the upper thoracic spine that's causing that. You could have instability at that level that's not being picked up on a static MRI. So lots of different things. And then again, I think I was talking to a patient before. This is the email that goes to my desk. So feel free to reach out if you're ever having a hard time getting through to staff on a particular issue. Just reach out to me directly. How much more effective is BMC over PRP for a 5-6 bulge? Most 5-6 bulges would be treated with PRP, not BMC. AT, thanks for your time and the educational content. Brian, hi, Dr. Last week you mentioned about 100 patients repeat DMX after PICL. True that results of video paper data analysis would be stronger than testimonials. You know, Brian, I don't want to do that because that's not a consecutive analysis, meaning that those are patients where we got a DMX either because the patient wanted one or the patient wasn't improving. So it's kind of a weird subset of information that would suffer from pretty significant bias. We did, and I think I've already put out there, the first 10 to 20 towards the beginning of us doing this procedure, where we're routinely doing DMXs. And then frankly, it was patients that caused me to stop, right? We had a large amount of chatter on the PICL Facebook group. Many patients were frightened about getting additional radiation. So I stopped doing this routinely simply because of the patient pushback, and now only do it when it's needed. And I don't disagree with the concept of getting additional radiation being concerning if there's no rationale to do it. So I don't think the data set we have right now on repeats would be representative because it's not 100 consecutive patients, for example. It's just usually patients that had some sort of squeaky wheel issue going on that we were trying to deal with. Brian, also maybe a mid-study update. How's improvement looking so far? Yeah, the data looks good. I've seen it. But again, we're doing lots of different data analyses. So it's going to be a while, be a couple months before we get the information in a good place. I'll probably submit it for publication and then put some version online even before actual publication, because then that delays it for 6 months or so. How do you treat concussions? John, we don't treat the brain injury component of concussions at all. I just find that a large segment of concussion patients have a brain injury component. The brain injury component gets better. Then they have an upper cervical component, and no one's ever looked at their upper neck. Brian Olson's, in one of your videos, you mentioned a Colorado State study where they CFU analyzed Wharton's jelly versus BMAC. I can't find the study anywhere. Try Google. Yeah, I'll pull that up. That's actually my study that was done in conjunction with CSU. Let's see. I'm going to type in Centeno umbilical CFUF bone marrow. And I know it's in the American Journal of Sports Medicine, but let's see what that gets us. There it is. So I think it's just a matter of typing the right stuff into Google. So let's see if I can share that screen with you. It's this one. So it's right here, colony forming potential and protein composition. So right here, I put in Centeno, umbilical, CFUF, bone marrow. So I think it's just a matter of putting the right stuff in. It was published in the American Journal of Sports Medicine. That's #1 orthopedic journal on earth, 2021. Basically, what we did was to look at the stem cell content of, I think it was 6 commercially available Wharton's jelly products, 5 Wharton's jelly, 1 was cord blood, if I remember. And then we looked at bone marrow from middle-aged and elderly patients. Now, if you go to the Regenexx website, without having to buy that paper, well, let's see, what can we get on full text? They always play games with this. Yeah. So you're going to have to pay for it here, which is some ridiculous amount of money. They charge you like 40 or 50 bucks to get access to the paper, which is obscene and absurd. So let's type in CFUF umbilical on the Regenexx site. Here it is. So this gives you a little bit more information, so you don't have to pay for it. That's some of the protein content, post-thaw viability, but this is really the money shot from the paper. So purple dots here represent stem cells that were alive and functional enough to form colonies. The umbilical cord products are above there: CharaCore, PurePro, RichGen, Stem L, UCB Plus, Stem Vive, etc. As you can see, they don't have any purple dots. That meant that there was no stem cells that survived in any of these long enough to form colonies and culture. Then on the bottom, you see the bone marrow concentrate of elderly people. Female 64, male 64, male 65, female 66, male 73. They all have lots of stem cells. So again, the hilarious thing is the scammers that were selling these Wharton's jelly products as stem cell rich. Babies have lots of stem cells, hence this is just a huge amount of stem cells. Turned out to be just scammers. There were no stem cells. And they were all making the claim that it was better because if you get older, you don't have any stem cells in your bone marrow. Obviously not true. If you didn't have any stem cells in your bone marrow, you'd be dead. So that's sort of a quick little tutorial on that. Brian may be sending blast all patients saying everybody repeated DMX, please send to us. Again, Brian, it's not real scientific, meaning that in my experience right now, people who are getting DMXs repeated are getting DMXs repeated not because every patient's getting a DMX, which is what you would need to do. They're getting it because something is concerning. Either they're freaking out on their side and they want to see if they're getting better, or they haven't had any results and we're ordering it or recommending a DMX. So it's not a scientific cross-section. Raj, hi, doctor, I hope you're well. Do you still offer the original PICL procedure? Do you have a better episode procedure? Why not offer that as standard of care? Does it come down to price and patient care? Yeah, we only offer the ePICL right now, so not the standard PICL. Can yelling aggravate CCI? Maybe, sure. If you get really crazy when you're yelling, you might be able to do that. Dina, just clarify, you do a lesser invasive PICL for more sensitive? Nope. I think I answered that one already. We don't use PRP for PICL, only bone marrow concentrate. Do your MVA patients usually have their head in rotation when the crash occurs? Some do. John Hank, how many months do stem cells keep healing? 3 to 9 if you count remodeling. Charmaine Jennings, I feel tight and tender spots inside my mouth that when worked on help my tension, pain, and trigger spots, my traps. What's the connection? You could have some cranial nerve 9 irritation due to craniocervical instability. If that's what we're talking about, that would cause the tender spots in the mouth. Jacob, I'm 21, had the PICL at your office 2 months ago. I've been in super flare this entire time. Occiput is in extreme pain. Do you have suggestions if that what might be happening? I do have hypermobility. Yeah, Jacob, you're probably one of those few patients that have a prolonged flare that lasts a couple of months. We just recommend that you reach out to whoever performed the procedure so that they can assist you. So whoever performed the procedure, you got to reach out to that doctor directly to hopefully you have their email. For some reason you don't have the doctor's email, just send an email to me and I'll hook you up with that doctor directly. Lisa, I went to a chiro office and got DMXs ordered. They set up an appointment with me for curve correction despite having a pending consult with you. I was not sure what to do. Yeah, I wouldn't automatically sign up for curve correction without first running it through us. Charlemagne, are there any plans to work with CCI surgeons at Fuse to prevent adjacent level syndrome? Really no way to prevent adjacent level syndrome after fusion. So I'm not quite sure what that one means. At least I need to clarify the question. I went to chiropractor's office and they sent, yeah, I gotcha. Charmaine, can orthobiologic ligament treatment result in a settled cranium to be raised? It cannot. Sharon, how Centeno can CCI usually cause gastroparesis and other bowel issues? If this is the only thing, would it be CCI at all? Yeah, so there would be a huge question as to whether it was CCI. If it was just bowel issues, meaning that bowel issues can be caused by 100 different things, including CCI. So if that were the only issue, then it would be very, very hard to make a concrete diagnosis that the CCI was causing it. Dina, can CCI cause vertebral press in the throat area? Can PICL and posterior PRP help this? It can cause that sensation, Dina, but I would need to know what type of the 8 different types of CCI you have, 1A, 1B, 1C, 1D, 2A, 2B, 3A, 3B, in order for me to say whether you needed PRP or PICL, PRP posterior or PICL. So realize again that each one of those types of CCI maps to what needs to be done. So you have to get a specific CCI diagnosis to see what it is you might need. Charmaine, can orthopedic ligament treatment result in, no, I think I answered that one. How are the results from patients? Yep, answered. Sharon, I think I've answered that one dozens of times here. There really isn't a difference in the end. It's just a difference in the number of treatments. In fact, in the third data analysis we did, we also didn't see a difference between EDS and non-EDS. I'm HF. How do you think there will be adaptation or spin-off for your PICL 50 years from now? I have no idea. I won't be alive to see it, so I have no idea how that will work. My guess is that we're going to see, just from a broad picture standpoint, many, many more interventional orthobiologic treatments. Eventually, that'll get insurance coverage. You'll see lots of injectable orthobiologics, everything from recombinant growth factors to supercell treatments, et cetera. So I suspect is that all of that gets bigger and bigger and bigger. It gets it gets better and better for patients. Brian, thanks for this study. I've had 2 BAs about lingering nerve issues during Wharton's jelly. If they can show a CFU analysis with the live product. Yeah, Brian, I wouldn't do Wharton's jelly. It's a scam. Meaning you're going to get scammed in 2 ways, right? Number one is the doctor or the mid-level that they're having doing it is not going to have the ability to put it where it needs to go, because that's the deal with clinics that use Wharton's jelly. They all have it's a money-making scam. So you don't want to hire a doctor that makes $500,000 or $700,000 a year, which is what these doctors make, that know how to do that, because then you won't make any money. They will hire instead a PA that they can pay $80,000 or $90,000 or $100,000 a year to, who doesn't know where to put it. And the second thing is they're not going to have a CFU-F analysis available because there are no living and functional cells. So you're not getting a stem cell product. You might be getting a growth factor rich product, but listen, there's been contamination issues in dozens of these products now, and dozens of FDA warning letters that have gone out about contamination issues. So I would just stay away. It is an unregulated Wild West space out there. And if someone's offering Wharton's jelly, they're almost at this point, with all the research that's been done, a scammer. Sharon, can using peptide injectables prior, during, not that I know of, no. I would be very cautious about anyone making those claims. What are your thoughts on upper cervical dry needling prior to regen therapy? Not a bad idea to give it a shot. Just make sure you're with someone who's experienced in doing it. That wouldn't be a chiropractor who learned some acupuncture. That would tend to be a physical therapist who's an advanced physical therapist who has gone through someone like Adel Zylestra's courses in trigger point dry needling and IMS, and they've been doing that for 5 or 10 years, so they're very comfortable dry needling the upper cervical spine. We've seen at least one subdural hematoma caused by an inexperienced provider doing dry needling of the upper neck. But if you can find an experienced provider, I think it's no harm, no foul. See if it works. Deanna, how successful is PIS? I think we got that already, Deanna. You're the OG doctor. The most of go to people say things and this condition is awful. The doctor feels questions like this or change like. Yeah. Thank you, Brian. Yes, I am committed to trying to make sure that people know which end is up. As you know, last month I did this in my car outside of a Safeway because the power went out at my house. Jacob, also feeling a jutting forward my throat vertebra. I think it's getting bruising in front of my throat since I'm 2 months out of the PICL. This can you remodel and potentially pull it back in place, feeling at the foot PICL treatment, but a lot of sensation in the 5-6 area. Yeah, Jacob, I think it's a good idea to reach out to the provider who did the procedure, who can probably answer those questions much, much better than I can here in this kind of forum. So you have my email address. It's up in the comments on all 3 platforms, or 2 platforms and 3 channels. So if you don't know the email address that goes directly to your provider, then just reach out to me and I'll hook you up. Dina, just to acknowledge what blessings for all that you exist. Thank you. Oh, thank you, Dina. Yeah, so with that, I will start wrapping this up. Again, all great questions. This is a safe space for asking whatever questions you want to ask. There are no stupid or dumb or non-educated questions. All questions are how we learn, right? We ask questions, we get answers. That's how we learn, and especially with patients, it's critical that they have a chance to ask questions and get them answered. And in our crazy medical environment that we have constructed here in the United States, all too often doctors don't take the time to answer questions. They're in, they're out. They maybe answer 1 or 2, but the patient had 12. So I answer questions, as my patients know, all day, every day. I field dozens of emails from patients a week sometimes, many of whom have questions that need to get answered. My staff does the same, and I do this every week to try to catch any questions I haven't answered from my own patients, questions from other doctors' patients, and just questions in general, so that patients can get a sense which end is up. And again, as I always say, an educated patient gets better quicker. An uneducated patient who never gets their questions answered, in my experience, is just frightened and doesn't know which end is up. So thanks so much for joining, taking time out of your busy Sundays to ask the questions. And I will be here next week, probably same bat time, same bat channel. It could be 9 or 10 Eastern, or sorry, Mountain. We'll see how that goes. And you all have a wonderful week. And I think happy Halloween. So next time I'll see you, it'll be after Halloween. So thanks so much and have a great day.